Good afternoon, folks. My name is Michael Creedon, and I'm chairman of the Aging Studies Project here at ATSU. And before I make a couple of remarks of my own, I want to read for you a letter from the president of the university, who unfortunately couldn't be with us today, and asked me if I would read these remarks to you. As president of AT Still University, it gives me great pleasure to welcome all of you today to the 10th annual lecture on aging. This unique annual event brings together faculty and students from throughout our schools, along with community leaders from Mesa and Kirksville, to address an urgent issue in the field of service of the elderly. The annual university lecture is truly multidisciplinary in nature. It brings together our campuses to reflect on the great challenges we face with the aging of America. It also calls us to dedicate ourselves to service to our elders. Each day for the next 20 years, 10,000 Americans will reach the age of 65. These older Americans can expect significantly longer lives than their ancestors. But our challenge is to make them healthier and more fruitful lives. Our Aging Studies Project was established by the university's Board of Trustees in 2004. Its goal is to help our students to become healthcare professionals who provide optimum healthcare for our older persons in America. I'd like to thank Dr. Michael Creedon, that would be me Mr. Elton Bordenave, Dr. Janet Head, and others involved in organizing this event. I also want to thank you, the students of ATSU, for your presence here today. Each year, the Aging Studies Project brings to our academic community a nationally recognized leader in healthcare. Today, I am very happy to welcome Dr. Joseph Flaherty from the School of Medicine at St. Louis University, who will address the issue of polypharmacy and the elderly. I cannot be with you today because of other commitments and service to ATSU, but I pledge my continued support for the work of the ATSU Aging Studies Project. Thank you all for being here, and may you have a very good day with this program. These are the words of Dr. Phelps. I want to add a few words of my own, fairly speedy words, so that you can get to the program. This year we have passed the number of 2,000 older people in Mesa area who have been trained by our students in falls prevention in the city of Phoenix and Mesa community, etc. Our work in that area has been recognized this year by the Center for Disease Control, and their new book on falls prevention and the elderly. There's a special section on ATSU's work as a national leader in falls prevention. And likewise, the National Council on the Aging in November in their bulletin had a special feature on the work of ATSU around the falls prevention area as a national leader in the field. So we are becoming recognized. But also here at this campus, the Health Partners Program is a unique collaboration with Truman State University, and our falls prevention in Mesa is mirrored in our home visits programs here at Mesa. And we have 160 students from Truman State and ATSU working together in visiting people in their homes and helping them with nutritional issues and so forth. Now, over the years that we've had the House Calls program and the Health Partners program, we have actually visited hundreds of people here in the Kirksville community. And so our students are engaged in outreach to elders in our community and helping them with the process of moving forward their lives. And we're delighted that some of our community seniors are with us here today who have been dialoguing with our students and learning from our students and teaching our students how to serve older people and how to be empowering to older people, because that is a learning process and students have to learn how to make sure that older people fully understand what they're up to and understand how to dialogue with health professionals. So it's a two-way education process. Thank you to all you elders who are with us today for the education you are giving to our students. I would also like to say that today we're announcing a couple of other things. We're announcing that a pilot project, it will be beginning shortly, for a new certificate program in aging studies, sponsored by the School of Health Management in association with the Aging Studies Project. And the pilot project will begin shortly, and that will have a course on understanding the aging process, and will have a course on the continuum of care for the elderly, plus field opportunity experiences with older people. We're providing scholarships for the students who will participate in that, but it will be a limited number of students, so if you're interested, you better get your butt in gear and let the people know at the Aging Studies program that you are interested in that program, okay? It's going to be quite limited in terms of numbers. But we will roll out beyond that a certificate in Aging Studies this coming year, distance learning based and open to our students throughout the country in their clinical settings, as well as to you here at the campus. So that is a major step forward, I think, in terms of our service to students wherever they are. The second thing we're announcing today is we are actually opening today a website for our Aging Studies project, which will tell you lots of stuff about the programming and the services and the opportunities for our involvement. So please go into the ATSU portal. You're going to find our website there. And Josh, do you want to tell them how else they could access it besides the portal? It's also on the home page. And I want to particularly thank Josh Pearson, who should stand up for a second, please. The man who actually created the portal. Give him a round, please, will you? Finally, I think that we need to remind you that our mission, established by the board of the university in 2004, was to be a catalyst for this university to develop our response to the aging of America. We have 43 million people over 65 right now. We're going to have close to 80 million in about another 10, 15 years. This is a tremendous challenge to our healthcare system. You are the healthcare providers of the next 20, 30 years. You need to be able to deal with this challenge. And we need you to be the leaders for the future in dealing with the aging of our society. So thank you for being here. Thank you for all the participation. Thank you, Janet Head, for leading the program here at this campus. And thank you, Elton Bordenave, for leading the program at the Mesa campus. Josh Pearson and Jackie Kalinski, our coordinators. Thank you also. We have a really good team. And we want to work with you, and we want you to know that we are open to you making phone calls to us. Thank you very much, folks.
Well, it's been a pleasure to work with Dr. Creedman for the 10 years of the Aging Studies Project, and you can see what kind of advocate we have in him as a leader in the Aging Studies program. With no further ado, you all have Dr. Flaherty's bio there in your little brochure, and I'm not going to say any more other than I'm so delighted he's here and this day has finally come.
Thank you very much. Thank you. Thank you. It is a pleasure to be here. Thank you, Dr. Janet Head, mostly for inviting me, but also for a great team. Josh helped things set up, and Dr. Creedon, folks I met last night at dinner. It's really a great pleasure to be here. Let's see if I can get this. Because coming to the pioneer osteopathic school to give this kind of a talk, it's probably the most stimulating time I've ever had to give a talk on polypharmacy. So as I was touring your museum before this, I found a quote from one of the visitors. The visitor was William Randolph Hearst, and in his quote he says, "Why does the hair on the average medical doctor's back rise up when you mention osteopathy?" By the way, I'm an MD trained, person, but I work with a lot of osteopaths at DePere Hospital, and now at St. Louis University. Of course, many of our residents are DOs. But his quote goes on to say, and please remember this when you graduate, it is because osteopaths do not place quite as complete reliance upon pills and potions as the orthodox doctors do. So I give this talk several times a year to third-year medical students. I've given it around the country, around the world. And I'll be honest, the MDs just don't get it all about how to not use medications. That's what they were trained to do. And I know you're being trained to understand medicines. I think I see the pharmacist, the pharmacology director in the back, one of your teachers. And how many of you are first-year med students? Okay. And so when did you already have your pharmacology class? Parts of it. All right, parts of it. So we'll get to the med list here in a little while on the sheet of paper. And those in Mesa, welcome. And I hope you've had some pharmacology background, because this will be a talk about medications, but not how to start them, but how to stop them. So, I have no disclosures. First, some basic principles and some research background, and that'll take about 5 minutes, and then the rest of the half hour that we have left, we will go to a patient-centered approach, and I will be the patient, you will be the doctors. I know we have non-physician trainees here, but we need your help too with this polypharmacy problem. So whether you're nurse or therapist or social work, you will identify with one of these definitions of polypharmacy. In fact, I don't care which one you pick. You can pick them all, you can use one of them, but try to remember that too many medications is bad. That's common sense. Now, why is too many medications bad? I'm not going to belabor the studies. Many people give talk on polypharmacy, go into the research behind this and how I can prove to you that too many medicines increase non-compliance and medication errors. You all know that. That's common sense. All right. So what I've decided to do is just give you two background studies, both done at St. Louis U, but I think they're applicable to what we're going to do here in the next half an hour. First one is a study of home care patients. So all these patients had home nurses going into their home, which is, as the partners will tell you, the folks that are at home and the students who go out there, where's the best place to get that medication history? It's in the home. Trust no one in the clinic. Trust no one in the hospital when they give you a medication list. Trust the patient, but trust them if they have their bottles in front of them. And that's what this study was about. Nurses went in there, they looked at the number of medicines, the type of medicines, and as you can see, the patients who went back to the hospital, on average, had higher number of medicines. You see, when you get up to 10, your chance of going back to the hospital is about 30%. If you stay below that, you have a lower chance. You get up there, you have this relationship. Now, what's wrong with this study? It's only observational. And when I show this to MDs, they always will say, well, these people are sick. They need all these medicines, right? So, years ago, my boss, Dr. John Morley, and another Irishman from, I don't know, he was not from Ireland, but Gordon Ireland was his name. He was a PharmD. And Dr. Morley and Dr. Ireland set up a clinic at the VA, the Veterans Hospital, called the Medication Reduction Clinic. And they looked for people just on 10 or more medicines. They didn't take everybody. They took people 10 or more medicines, age over 65, and they invited them to the MRC. Not everybody came, so there's a little bit of bias. We don't know that the usual care group, maybe they like to take all their medicines. But there were a group, 70 out of 120, that came to the Med Reduction Clinic. On average, each group was on about 13, and you can see the range there. So what do you do next when you have all these medicines? Well, one of the principles I'll show you is you have to do comprehensive geriatric assessment. Then you start reducing medicines. You can't just go at it with the sword and start slashing. You have to look at the geriatric issues, follow these people over time, and then start whittling away. Well, the Med Reduction Clinic group got from 13 down to an average of 8. The usual care group over that period of 2 years was the study, went from 13 to 14, right? Doctors don't stop medications. We're afraid. Oh, some other doctor started it. It must have a good reason. So they showed decreased hospitalizations in the med reduction clinic group, 54% versus the usual care group. There were even fewer deaths in the med reduction clinic, but it wasn't statistically significant. So what you can say from that study is that it's safe. They didn't kill more people by stopping their medicines, but they did potentially prevent hospitalizations. So that was the outcome they looked for. So, before we get to the case, here are the 3 principles. First, I mentioned CGA. Second, and this kind of rubs people the wrong way sometimes, is how long will people live? Life expectancy. Will a person live long enough to benefit from the pill, that's the benefit, versus the side effects? You wouldn't want to take a pill that's going to work for you in 5 years if you might only live 1 or 2, unless the pill improved your quality of life or something. So yeah, we have to think about life expectancy in some respect. And then the third one is prioritize outcomes. The person in front of you, that patient, what is important to them? Is it the number on the blood pressure screen, or is it something else? All right, so here's in a nutshell, comprehensive geriatric assessment. Why do we do it? It's interprofessional, by the way, very interprofessional. I can't tell you how much I depend on all other professions to put all the pieces of the puzzle together. We develop targeted treatment plans, and the whole goal, improve patient outcomes, especially keep people out of nursing homes. Of the young people in here, who of you want to live in a nursing home when you're 80? Yeah, Mesa, anybody want to live in nursing homes out there? Okay, I didn't see any hands. Now, if you have to, nursing homes are a lot better than they used to be, thank goodness. But it's just not the place we'd all like to end up, unless we really need it. And then the big focus here now is on function. May or may not be life expectancy, but function. All right, so here's a long list of what we do in geriatric assessment. You would think it would take hours, and sometimes it does. But we do have to assess function. Okay, let's see if my little pointer here works. There we go. Dementia, depression, falls, weight loss. Of course, polypharmacy is an issue. We do blood pressure sitting and standing. So I'm not going to go over all these. That was just to give you a snapshot of our first approach to the patient on too many medicines. I'll mention a couple. One is the St. Louis University Mental Status Exam, which I know many, if not all, of your students are exposed to this. They do it. It's a very good tool. You can do it on your friends if you want, see how their mental status is before and after exams. But I think it's a very good screener. It's better than the old days mini mental status exam. It's a little harder. It picks up on early cognitive impairment. We should not be afraid of dementia, whether it's in our families or our patients. We should try to identify it early, talk about it. We don't have any cures yet, but we have a lot of things we can do to help the patient and the family deal with that as time goes. I mentioned blood pressure always standing as well as sitting to look for drops. So, is there any evidence? I guess I do have a few evidence-based slides just for the record. So, evidence-based medicine, you have to look at randomized controlled trials to see if what you're doing really makes a difference. And here are 28 controlled trials of CGA. The GEMU, IGCS, HS, these are different locations where the researchers did the CGA. Now, what's a good outcome? Well, one good outcome is mortality. If you do CGA compared to usual medical care, where the person goes to the doctor, they get their prescription, and they go on their way, CGA can reduce mortality down to 0.73 or 27%. Decrease 6-month mortality by 27%. Decrease 12-month mortality by 22%. Not bad. There's not many pills around there that we can reduce mortality by that percent. Takes a lot of work, but it's doable. And then here's the big one for me is, what's the odds of this person living at home if I do the comprehensive geriatric assessment? One of the reasons I went into geriatrics is that my great aunt My grandmother's sister went into a nursing home. Then my grandmother went into a nursing home. And I wanted to do everything possible in my career to keep people out of nursing homes. 26% better chance, almost a 50% better chance at 12 months. So pretty good stuff. Not high tech. I'm sorry, we don't have some high tech cardiac catheterization to keep you out of a nursing home. But we do have hands-on stuff. Okay, that was the first principle, CGA. Second principle, again, a touchy issue. How long will people live? Pick on the women. How about it in Mesa? Mesa, do you know who lives longer, men or women? Women, yes. And so we don't know why. If anybody wants to do research in that area, it'd be welcome for us men. We don't know why men don't live as long. But how about a 70-year-old woman who's healthy? How long? You seeing that? 10 years? 20 years? How about 21? 21 years if you're healthy. If you're average, over 15. If you're frail, again, the definition of frailty is evolving, and people are having consensus groups as we speak probably of what a frail person looks like. But this helps you a little bit, and then you can calculate the numbers from there. More than 10 years. So here I'll give you a quick example. What if your patient is 80 years old and does need a heart surgery? I've had many heart surgeons refuse to do surgery on my 80-year-old patients. They're too old. Well, I hate to hear that. Nobody's too old. People are older, but you have to put it into perspective. If the risk is relatively low and they do a good surgery, that person could live another 13 years. Now, if they're frail, let's take frail or average at the age of 90, I might still push the surgeon, but I might not if the life expectancy is a little lower. So this is how you start to use life expectancy. Do I ever talk about this with patients? Not directly. Sometimes I will bring it up and say, how long do you want to live? How long do you think you're going to live? And I get all kinds of answers. That's actually a cool question to ask, because it's very open-ended. It's all from their perspective. So here's just an example of how you might use life expectancy with medication. Long time ago, almost 20 years ago this was published, 30 years ago, or 20 years ago. This is a cholesterol pill, simvastatin, compared to placebo. And the way these drug companies did the study is you give the pill at time 0, and 100% of people are alive. 100% of people are alive. As time goes, this is 1 year down here, 1, you can see that. Hope you're following this, Mesa. And after 1 year, a small percent, what percent of people have died after 1 year? There's 0.9 survival. So it's probably 0.99 survival. So 1% have died after a year. So here's just a little bit of side note. Drug company studies, you have to be careful how they present their data. This data looks great. The curves go down, and then the blue curve, which is the cholesterol pill, doesn't go down as fast as the green curve, which is the placebo. This pill must work. This is a great pill. But if you don't know how to read the research, you come out here and you say, let's see, the curves start to split. Well, let's come out here to 5 years. After 5 years of being on the cholesterol pill, that's probably 0.92, maybe 92% of the people are still alive in 5 years. Now, if you just take the placebo, the sugar pill, you're 90% chance you'll be alive. So that's not bad. I'm going to take a placebo pill. But so there's a 2% difference after 5 years of taking this cholesterol pill. So now you bring the life expectancy into the equation and say, boy, my patient's 85, they're frail. Life expectancy is probably 5 years, but they hate taking this cholesterol pill. Should I force them to take the cholesterol pill for a 2% difference in chance of dying or not dying? Now you're talking. Now you're balancing risks versus benefits. Okay. Last one. You've got the CGA. You've got the life expectancy in the equation. Now you have to ask your patient what's important to them. What do they live for? Well, first thing is they live to stay out of the nursing home many times. Maybe they live to see their grandkids. Be careful when you ask that question. I asked it one time, a patient needed a surgery for an aneurysm. The aneurysm in the abdomen was growing, it was growing, and we're like, we really need to do the surgery, or if it busts open, you might die. So I said, well, sir, how long do you want to live? And he points over to his daughter-in-law, well, I thought was the daughter-in-law, and he says, I'd like to live long enough to see my grandchild. And this daughter-in-law blushes and said, well, we're not even married yet. So to him, it was waiting for my grandbaby. And how long was that going to be? And that was his motivation for living. So am I going to do the surgery to help him live 5 years or 3 years, 2 years? That's the question. Now, keep in mind, cognitive function is a big issue for all of us, especially as we grow older. I don't want to give medicines to my older patients if it's going to affect their thinking, if it's going to affect their gait, to make them fall and end up in a nursing home. So a lot of these things make a difference. Okay, so those were the 3 principles before we get to the case. I've got 2 more little slides. If you see any of these symptoms, this is just one of those little pearls that you may need to remember when you're seeing patients in the hospital or in the clinic or in their home, and they complain of any of this stuff, look at the med list. Look at the med list, see if you can find any that cause some of these. A lot of medicines cause a lot of this. And then you're saying, wow, maybe I should take a chance in trying to stop some medicines. Any of these vague symptoms, think drugs. And then here's the guide. Here's our guidance. This is what I'm going to leave this slide up to give us guidance on the patient you're about to meet. And this list, this checklist, is going to help guide us. So I'd like everybody to take their piece of paper now. I think, Mesa, you have the case report. So on one side of the case report is the medication list. And if you want to count, you can, but I counted. There's 19 medicines listed. There's a couple duplicates in there. You might not know what some of them are. Maybe we could pull in some of our seniors and ask them if they know. They probably know these medicines more than some of our medical students at this point after pharmacology. But we're going to get to this list, and our goal is to take that list in the next 20 to 25 minutes and to whittle it down to about 2 or 3. 2 or 3 is the goal. The goal is to get down to the most minimum drugs. Okay. All right, now, Mesa and Kirksville, I'd like you to meet your patient. I am 84 years old. I am the patient. And I am a conglomeration of patients I have met over the past 20 years. And my answers to your questions, I'm in your clinic today, you're seeing me, and you're going to ask me a bunch of questions, especially about my medicines, and I'm going to give you answers that I have heard over the past 20 years related to this long list of medicines. All right? And I thought we would do this rather than show you study after study after study of why this is important. You know that. This is hands-on. I want you to take some of my medicines away. But there's a little bit of an art to doing that. Again, you can't come in and just tell me, Miss Jones, you're 84. I had a lecture and I'm going to take you off all your medicines except 3. So there's a little diplomacy going on here. A little dance. You have to dance with the patient sometime. Why are you on this? Well, do you like to take this? You don't like to take that. So, okay. So I'm in your clinic. I'm 84 years old, DJD, and I'll give you some of the abbreviations. Stands for degenerative joint disease. I have arthritis in my hands, basically. You just read the chart, and that's all it says in the note. The last note says DJD and hypertension. Okay? And I tell you, yeah, today my hands kind of hurt. Overall, I'm doing okay. You look in the past medical. You can read that, pneumonia about a year ago. You go through a full review of systems, head to toe, no headaches, a little bit of dizziness. I just lost my balance. I have some GI problems. My bowels are kind of slow. Oh, and by the way, my nose kind of is runny off and on. But no shortness of breath, no chest pain, things like that. My exam, again, sitting and standing. The blood pressure drops just a touch on the systolic. I'm 5'4" and 102 pounds. So do I sound thin and frail? Yes, that's the picture you want to be thinking of. Thin and frail. Skin, head, eyes, ears, nose, throat, if you don't know that abbreviation. Negative. Pretty much negative exam. You can see the regular heart. I threw in a positive S4. When you listen to the heart, you hear the S1, S2. S3 is abnormal in older people. S4 is within normal. It's a normal variant in older people. So the reason I put it in there when I give this talk to third years, I try to trick them. And they're thinking, oh, the person's in heart failure. I said, no, an S4 is the normal variant. Is she in heart failure? She is not in heart failure. You know a little bit about heart failure? You had your cardiology? But she has this, what's this puffy ankles? It's not pitting. It's not pitting. But she has edema, swelling of the ankles. So I'll tell you a little story about that. I may have been able to pull in some of our home older patients about that. Now, you get her up, you walk her around. She does okay, but she hangs on. Is that a normal? That is not normal to hang on while you're walking around. And then her slums is very good, almost a 30 out of 30. She's 27 out of 30. The GDS stands for Geriatric Depression Scale. On that scale, it's the opposite. The higher your score on the Geriatric Depression Scale, the more likely you are depressed. So she actually has a low score. So there's no suspicion of depression here. Okay. So that's me in a nutshell. Now what I'd like to do is take the Kirksville folks first, and we'll go back and forth between Kirksville and Mesa. So I'll let someone in the audience ask me, the patient. You can ask me why I'm on a medicine. You can ask me to stop it, but the goal is each time we do one, we'll try to stop a medicine. And then we'll go to Mesa and let them stop a medicine, and then we'll come back and forth. All right, so Kirksville, anybody want to take a shot at why I'm on something? And I'll repeat it so the Mesa folks can hear. Ginkgo biloba. Yeah. Yeah, what, do you know much about ginkgo biloba? Oh, you said, so the student here said, the doctor here said it has been shown to have an effect. Yeah, well, should I better keep taking it though. Why? Ask why. Why? Well, because my daughter sent it to me. And I don't want to upset my daughter. Wait, you got to stick on the same one. Otherwise, we'll never stop. Well, we'll get to the coding. So you want to keep asking me?
Do you feel like it helps your memory or your cognitive?
Well, did I do pretty good? I did pretty good on that slums you just gave me. I did a 27. I did. How come my daughter sent it to me? I don't know. She lives in California, for one. So, she doesn't live in Phoenix. She lives in California. And I guess when, sometimes she calls me, she says I sound confused. And so I say, well, just okay, if you want to send me the pills, you can. But if you think it's okay to stop, will you call my daughter?
Sure.
Oh, perfect. So that's the right answer. Yes, I will call your daughter, explain to your daughter that you don't have dementia. Your slums is good. And then when you call the daughter, what other information are you going to get? When does the daughter call and why does she sound confused? So the story is building here. So we'll stop that one. That's an easy one to stop. So remember, each piece of these little snippets are the big story. So we'll come back to this daughter thing. Okay, Mesa, do you want to ask me about a medication? Oh, the codeine. Oh, yeah. That codeine. Oh. Kidneys and liver. Oh, no, I read you can take up to 3,000. It won't hurt you. As an aside, so I'm going to step in my doctor mode. So Tylenol is still one of the very safest drugs we can prescribe. And again, it's been blown out of proportion by the media because of overdoses of Tylenol. But Tylenol, 2,000, 3,000 milligrams in the elderly is still safe on the kidneys and the liver, just making sure you don't have other drug interactions. So, but you still want to address it because of the codeine. So the codeine, she'll respond to you by saying, well, codeine, I didn't know that caused constipation. Okay, well then maybe we should I stop it? Oh, okay, well, but then, do you want to know why I take it? Oh, I take it because it helps me relax at night. All right. So again, you don't know unless you ask. So what she tells you is, I live in kind of a bad neighborhood in St. Louis on the south side, and it gets dark and I hear stuff out in the alley, and so sometimes I'll just take one of those or a half, and it relaxes me and it works pretty good. Is that okay? Oh. Oh, there you go. Now we're talking. So what you just mentioned was alternatives to medications. Again, third-year med students in the MD program will always tell me, let's put her on a sleeping pill or an anxiety pill. And I'm like, no medicines. No medicines. Yeah, white noise is a very good idea. What other can you do for her neighborhood? Tea, warm tea, herbal tea helps her relax, right. So I'll just get to, some people say maybe a dog, but maybe that would increase her fall risk. So you have to balance that. Yes, any other ideas?
Can I have a martini?
No alcohol. No, you get it. I know that's, I'm glad it always comes up because, again, you're trying to balance the risks and the benefits. So alcohol is not, it's not a complete negative, but it's always the balance, the risks versus the benefits. So again, try to stick away from that. If they already have a little wine or something, it's possibly okay. Yeah. Yes?
I would be interested in who's her support system at home,
Excellent. So she said, what's your support system at home and who's your communication? Well, my daughter calls me every night on her way home from work. That's my only person calling. Oh, wait, I do have this neighbor. This guy lives next door to me. He's from Mexico. He works really hard, but he really helps me out a lot. Brings me food over. So he's a good guy. So you can have the neighbor check on her at a certain time. Right. Okay, now we're making progress. So we're gonna stop the codeine, and when you stop the codeine, you better stop what? The laxative, right? Otherwise she'll call you because she has diarrhea. So we got rid of two, docosate and the codeine. We talk with the neighbor, we talk with the daughter. So what time should the daughter call her? When it starts to get dark in St. Louis, not on her way home from work in California. All right, so just as an aside, now let's get back to the daughter. When do you think why was the daughter thinking she was confused? After she took the codeine and Seroquel, so she's taking two medicines in the evening. How did she get on the Seroquel, for God's sakes? You know what Seroquel is? It's for what?
bipolar, depression,
Schizophrenia. Great. Those are the three big ones. A+. Your pharmacology teacher's doing good. Schizophrenia, bipolar, plus or minus depression. Be careful with that one. There's some evidence. What the heck is she taking it? She doesn't have any of those. How'd she get on that one? She tells you, you look at the bottle, and the bottle refill. She's been taking it about a year. How did she get on that one? She was in the hospital. Thank you, Mesa. Yeah, a year ago. That's what it tells you. She had pneumonia a year ago. And she got on the Seroquel because someone thought it would help her sleep. This is a true story. I've had patients come out of the hospital. I remember one that he's like, he showed me the bottle. He says, yeah, they gave me that. It's a great sleeping pill. And he gave it to me for sleep. So inappropriate use for the wrong type. Yes, over here.
So very good question. So now you have to delve into what's going on at night. So you ask her, do you have trouble sleeping? And she tells you, no, I don't have trouble sleeping. I can barely wake up in the morning. So she was taking the Seroquel every night because she was told to take it at night when she went home from the hospital. She didn't know it was a sleeping pill. But she just kept taking it. Now she knew the codeine helped with her nerves. And then she was taking one other pill at night. Tylenol, that's right, Tylenol PM. And the story behind that is, if you have to ask her neighbor, where'd you get that medicine, Miss Jones? Oh, my neighbor gave it to me because I told him about my arthritis, and he rubbed some peppers on my hands. That didn't work very well. And then he gave me this medicine, Tylenol Powerful Medicine. Got it? Okay. PM. What is the PM? Benadryl. It's Benadryl, diphenhydramine. Again, she didn't know it had diphenhydramine in it. So bam. And then she takes all that stuff and her daughter calls her while driving down one of those highways in California. Mom, you don't sound too good. I'm fine. You know? Okay. So let's get rid of the Tylenol PM. She's happy about that. Okay, back to Mesa. Any questions or? Questions. Yeah, so she says, so it's April, and she says, yeah, I started taking that back in December when I had this cold, and I just can't get rid of this runny nose, so I keep taking that Sudafed 2 or 3 times a day. Makes me pretty nervous, by the way. Yeah, so should I stop that? Yeah, so why does she still have a runny nose? And it's not on the list. It's reflux congestion, but not necessarily from the Sudafed. So when you're not looking, you're writing your note in the computer or taking some notes, she reaches into her pocket and pulls out this little thing and goes, what was that? Afrin, right. And so Afrin, after 2 or 3 days, causes rebound rhinitis. And why did she not read the back of the bottle on Afrin? Has anyone ever seen the Afrin? It's too small. It's about 4 font. Yeah. So you have to get her off the Afrin, then off the Sudafed. That's right. Okay, Mesa, good job. Back here, anybody want to? Go ahead. Oh, this is a great one. Did you ask? Okay, 2 good questions. Why are you on the digoxin? Now, the story behind this one's a little bit long, but she says, wow, I think I've been on it longer than you've been alive. Okay, there's a clue. She's, what, 25, 30 years? Yeah, back when I was in my early 60s maybe, I went to a doctor, and he listened to my heart and pushed on my ankles and gave me that pill. What did the doctor diagnose her with? Heart failure based on listening to the heart and pushing on ankles, puffy ankles. Now, was that doctor, it was not a bad doctor, but we didn't really have any back 25 years ago? We didn't have the echo 25 years ago, and what heart medicines did we have back then? We didn't even have those. So ACE inhibitors haven't been around that long. So all we had back then was DIG, and so she got started on DIG, and no one ever stopped it. Ever stopped it. So is that a good one to stop? Yeah. So again, there's very few indications for digoxin if you ever see that. Once in a while, we still use it for AFib if the other medicines don't work. Once in a while, we use it for heart failure, but it's like 4th or 5th line. Now, one other quick story about, 2 quick stories. So the seniors in the room, did you ever heard the term shoot an ankle? It's a way old term. You might be too young. So the term means when I'm young and pretty and I'm 20 years old, this was 100 years ago, on the street, I couldn't show my arms or my neck or my midriff, but I could show my ankles when I walked along the street or when I took the streetcar. So if I had skinny, sexy ankles, I could take my ankle. You can't see this, Mesa, but you shoot the ankle towards a guy to get his attention. I always thought this was myth until I had a little old lady that came to the clinic, and I asked her, even though despite her dementia, she says, "Oh, I know what that is," and she did it. So, but anyway, skinny ankles, not to make fun of, but people come in, and doctors in the future, senior ladies will want skinny ankles. Be hesitant to give them those diuretics. Be hesitant. All right. Now, the other side of the story is that we had a guy at the VA in the med reduction clinic, and he pulled out his digoxin and didn't know what it was for. And he opened the bottles, poured 4 or 5 in his hand, and he says, "Oh yeah, when I get real constipated, I take 4 or 5 of those." But it worked. Why does it work? Because the side effect of digoxin toxicity is diarrhea. It also has some other side effects too, but okay, so we're stopping it. Okay, let's go back to Mesa. What do you want to stop or ask me about?
Okay, I have a question for you. She's really taking 2 different strengths of hydrochlorothiazide, plus calcium channel blocker, plus an ACE inhibitor, plus additional calcium.
Good question, because sometimes what you get is, well, no, I don't take them all. That's a very good question to start with. But sometimes you'll get the answer, well, yeah, because my doctor told me to take all these. So in fact, you look at the bottles of that HCTZ, and there's one doctor on one bottle and a different doctor on another bottle. Now, what could have happened, you have to kind of delve into it if you're interested. Maybe someone told her to stop one and change to a different dose, but she forgot. Maybe they told her too many things that day in clinic. So, but this happens. People have duplicate medicines. So, you verified, I do take all 4 of those. What should I do? Yeah, what should we do? So I am taking all those.
Can we do a therapeutic trial and take her off of the lower dose of hydrochlorothiazide, and maybe take her off of the calcium at age 85, and make sure that's not interfering with her digestion?
Oh, okay, let's be brave. That's a good answer, but I'm going to go one step further and say, whoa, what is your blood pressure, and why are you kind of hanging on as you walk? Remember, one of the risk factors for falls is low blood pressure, and her blood pressure is too low. What is the goal blood pressure? Now, this is an evolving answer, so if you say we don't know the answer to this question, it's okay. But the question is, what is an acceptable blood pressure for an 84-year-old woman that's never had a heart attack or stroke or diabetes? One how much? Okay. So I'm here at 140, I'm here at 170, maybe. So we're finding out that maybe a higher is a little bit better. Maybe, so here's the data behind this. So we know that as you age into your 70s and 80s and 90s, systolic hypertension goes up, and that increase is associated with more heart attacks and strokes. So when you get above 140 and 150, the risk of stroke and heart attack do go up. But how many studies do we have of 80-year-olds and blood pressure treated above 140? 0. We have one international study of elderly, 80 and above, that's the key, it's not 65, this is 80 and above, blood pressure greater than 160, and you treat them versus placebo, you will have better outcomes. Again, what's happened over time with the blood pressure in the JNC 5, 6, 7, and now 8 is everyone's jumped on the bandwagon and said, boy, lower is better. 130 is better. 120 is better, without doing the studies. So the one study we have looked at people greater than 160, randomized them placebo versus medication, and brought them down to an average of 150. They didn't even go for 140. Average of 150, and they had better outcomes. So I have to say, if you're in your 80s and you've never had a heart attack or stroke, I don't think I'm going to try to get you below 140 if you come in at 150 or 160. Now, if you come in at 170, there's consensus. We want you down a little bit, but I'd say we don't even know that. At the conference I was at last week, there was a presenter, a researcher, took people who were 100 years old, had a large group of 100-year-old people, about 160 of them. And the folks, and they followed them for a year. The group that had the highest blood pressure lived longer than the group who had lower ones. And there was a curve. So just be careful what you hear and what you read in your textbooks. Again, this is why we do geriatrics, because sometimes the rules are a little bit different until we do the studies. Okay, so her blood pressure, let's stop the nifedipine and see if she'll get up to 140. That's at the minimum threshold. I may let her get up to 150. If she feels better at 150 than she does at 140, I may let her stay at 150 if she feels better. Again, depends on the outcome. She doesn't want to be in a nursing home. She doesn't want to fall. So get rid of the nifedipine. We'll get rid of the HCTZ, the big one, 25. I'll stop the captopril. Leave her on that little half a pill. Have her come back in 2 or 3 months. And in 2 or 3 months, if her blood pressure's still like 120s, I might stop that one. That's okay. It's okay to stop medication. One of the biggest causes of having high blood pressure when you're in your 50s and 60s, then you get into your 70s, and unfortunately some people lose weight in their 70s and 80s, which is bad. But if you lose weight in your 70s and 80s, your blood pressure starts to go down, but no one stops your pills. So keep that in mind about that weight loss. Okay, back to Kirksville. You have a question?
Could you tell me about all the multivitamin and the calcium and vitamin E and vitamin C and vitamin?
Great question. So Mesa, the question was, tell me about all those vitamins, vitamin E, vitamin C, multivitamin. And that's a very good way to approach vitamins. Tell me why you take these and what you take them for. As opposed to, Miss Jones, none of these vitamins work, so you don't need to take them. Okay? So some people love their vitamins and they believe in them. Some people take them because they've heard their friends take them, and so they feel obligated and they want to take them. There's various reasons. Just find out why. Now, as a doctor and as a prescriber, you have to ask yourself first, is there any evidence that vitamin C or vitamin E or multivitamin keep people like me out of a nursing home? No evidence. No evidence that vitamin E, vitamin C, or multivitamin keeps 80-year-old people out of nursing homes. Not that the studies have been done, but there's just no evidence.
Would you want to also look at the patient's diet?
Well, that's a good question. So the patient's diet. So even if I eat my neighbor's Mexican food, and it's fried, and it's great, and I'm maintaining my weight, I don't eat very many fruits and vegetables. I hope there's no dietitians in here, but is vitamin C really going to do the trick? Maybe not. Now, do you want to look for vitamin deficiencies in an 80-year-old? Yes. And this is why you want to learn about nutrition. You want to know what the symptoms are of vitamin C deficiency. Or vitamin D. You want to check that maybe, because that's risk for falls. But don't do the blanket approach and saying, hey, young people need to eat a good diet and lots of fruits and vegetables. And if they don't, they need to be on a vitamin. Don't do a blanket approach. So she'll tell you, no, I eat pretty good. I eat a couple vegetables a day. I'm okay. I just take them because, my daughter told me to take them. Well, you can stop them. And in fact, in the Med Reduction Clinic trial, one of the big groups of medicines we stopped were vitamins. And why did that improve outcomes? Not because they have side effects, but they improved compliance with the other medicines that you really need to take to stay out of the hospital. Again, if you think about it, if you wake up in the morning, you've got your heart medicines and your blood pressure medicines, and then you have your vitamins. Your vitamins don't make you sick, unless you take too many. But the other ones make you kind of tired, weak. So you're like, today I'm just going to take my vitamins. I got to go out with my daughter. I'm not going to take my water pill. I got to go out with my daughter today. I'm going to take my vitamins. So there's numerous reasons for vitamin use, but you did a good job by an open-ended question. If she's open to it, then no, I don't think you need vitamin E or C, or even a multivitamin. Okay. Got rid of 3 of them. Okay, back to Mesa. Got a couple more we could go for.
Is there a reason that she's on or that you're on the Pepsid? Is there acid reflux or is it kind of
No, I love the hot sauce. Got no acid reflux. In fact, I think that medicine, I've been taking that for about a year. Hospital, right. Another hospital medication. Again, doctors are afraid to stop it. Someone must have used it for a good reason. She got on it, no one stopped it. So, that's a good one. You want to take another one, Mesa? Throw it back here. All right, Kirksville. The statin. Is that what you said?
Yes.
What the world is up with that statin? I'm 84. Have I ever had a heart attack? Nope. So ask me, what about my cholesterol? Oh yeah, 2 years ago I went to this, I went to the mall and there's a bunch of medical students doing screenings for experience. And they checked my blood pressure and they stuck my finger for diabetes and cholesterol, and they told me my total cholesterol was over 200. So I took the report to my doctor and he put me on that 2 years ago. So is there any evidence? That's right. Again, there's a good head shaking back there. No evidence that treating high cholesterol in people in their 80s without heart attack, without stroke. So if you've never had a heart attack, never had a stroke, there's no evidence. There's no studies with statins in 80-year-old people, okay, to show that that can prevent heart attacks and strokes down the road. So why do doctors treat this number? I don't know. I'm seeing some seniors in the audience squint their eyes. I'll bet you're on. You don't have to admit it, but I'm sure you're on a statin, because I'm sure your doctor was trained to check cholesterol. But there are reasons to check cholesterol, meaning LDL and HDL, and that's if you've had a heart attack. You do want your LDL low. But you don't need it in someone like this, I think. So you have to individualize. So that's a good one. Now, if you're nervous about stopping statins, at least cut it to the lowest dose, recheck the lipids in 6 or 12 months, and if they're still acceptable, at least you got them on a low dose. I've had numerous people that are on 40 or 80, because the more the better, right? That's what MDs learn. Bigger the bang. Get them down to a low dose, their legs feel better, they can walk better, and their cholesterol's fine. Yeah. Good one. We got one more. Anybody know what that Trentile is? It's, yeah, viscosity. That's right. That's how it works. It's an old drug. I never really see it anymore, but I put it on there because there's a good story that goes with it. So it's used for what's called claudication, which is pain in the legs when you walk. And this drug is supposed to change the viscosity of the red blood cells to help them slide through the arteries better. So she got on it. Actually, my VA patient, he got on this drug because his legs hurt. And nobody asked him where. They just said, oh, your legs hurt. When you walk? Yeah, when I walk. Sure, when I walk. Well, no, it was when after he walked. And then finally, the med student, I think it was, like, where do your legs hurt? And you can't see this, Mesa, but he pulled his pants up, he grabbed his knee. He goes, yeah, it hurts right there. He had arthritis of the knee, and someone put him on a pill for blood, to thin his blood for claudication. So these things get started. That was the take-home message there. So we got rid of that. She's still on calcium. You can check to see if she has osteoporosis or osteopenia if you really want to know. Calcium's pretty safe. You could add some vitamin D to that, or you could check a vitamin D level, which is very common. So now you just have her on Tylenol and calcium plus vitamin D, so you actually got her down to 2 drugs. Good job, everybody. All right. Okay, questions? All right, a few questions, if any. Yes, sir. Please.
Why is that wrong with a drug we know you can make it all right?
Yeah, so it is the question was about the issue of primary prevention and the use of statins. And the fact that financially we're a little bit strapped, and so nobody wants to pay for a study of people over the age of 80 to randomize them for years between placebo and statin. Well, I don't know how to answer that, except I think until I don't want to extrapolate the data to someone in their 80s, because I know how long it takes for someone in their 60s to benefit from that pill. For this lady, it is primary prevention. So again, primary prevention, you have to treat a lot of people to prevent one outcome. So the number needed to treat is very high in primary prevention.
And I guess my next question, and I'll do it with two times. This happened again. I probably would have asked the question of whether she was happy about it.
Right.
That would lead to the
Ginkgo biloba. Ginkgo biloba.
probably agree with people that are not studying fish oil that is on part of it. There's no evidence but every major study likes to see whether it does no harm.
Right.
So should people stop for ginkgo biloba or fish oil? You talk about no benefit.
Yep.
And I agree with you there. You didn't talk about
No harm. Great point. So here's the, I think, the appropriate answer. So this gentleman asked about if there's no harm from the drug, like fish oil or ginkgo, what's the risk of taking it? And I would answer, I would agree. If a patient really wants to take those, and I truly think there's no harm, it's okay to take them. But if they're on 5 or more medicines, and they want to take all this other stuff where there's no benefit, then I'll say, hey, the risk is high because you've increased polypharmacy. Yeah. So if they're only on 2 drugs and they want to take another fish oil, I'd say, that's fine. You're taking your important meds as well. But if they're on 10 and they want to, and someone wants to add stuff, absolutely no. That help? Does that make sense?
Yeah, so now I can put your question.
Plus cost. Keep in mind cost. People pay for these drugs. That's another side effect of fish oil and all that stuff. Just eat a teaspoon of olive oil.
I would mention that some of these drugs,
Now they are.
I don't buy into that cost argument.
That's right. Need some ginkgo. By the way, there are ginkgo studies out of Germany. Ginkgo compared to placebo, there are some positive outcomes in those studies. And you look at the drugs we use for dementia, Aricept and some of these, the studies, if you took the name of the drug out, look very similar. So you wonder, what are the drug companies doing that make all this money versus people who try to push ginkgo? I mean, it's quite similar. So, okay, yes. Mesa, yes, question?
It sounds like you're confronting a huge issue, and over the last 10 years, it's really becoming more of a forefront. Can you speculate about how we're doing in confronting the problem that you're presenting today? How well we're getting along with that, and not with reduction or not reduction, things like that?
Wow, that's an honest question. With my honest answer is we have been looking at this, I don't know how many, 20 years in the geriatric literature. And again, I'll go back to that conference I was at last week, and there was an international expert in this area, and he pulled all the studies, in the intervention studies in polypharmacy, and trying to reduce adverse drug events. And everybody in the audience was amazed at how negative all the research has been in this area. Big interventions like pharmacists working with doctors and writing out recommendations. And then now we have these lists of potentially inappropriate drugs based on consensus panels, and they try to get people to stop those. So the group I was with finally decided that all the research they've done in the past 20 years, it's not having an impact because, and here's the honest part, is because prescribers physicians continue to prescribe, and we continue to learn to prescribe. And so when a pharmacist or a consensus panel tells a doctor, who I've been prescribing for 20 years, mister, I know what my patients need. I think that's what we came as a group to last week, was the interventions are not the right interventions. It's the prescribers have to stop the medicines. So I guess that's why I'm happy to be here.
What have you seen that works in convincing physicians to prescribe less?
Again, honest answer, I haven't seen anything. Pharmacists have not had it. They have a small impact, I'll be honest. Some good PharmDs, the best pharmacists are ones that can have control a little bit and get the physicians to trust them and stop and just, they make decisions. But no, it's an uphill battle. I have not seen anything that convinces physicians. Yes?
Is it of any use? I worked for an internal medicine clinic where there was like a leadership team about reducing polypharmacy, and I personally saw many physicians going through the med list at certain ages and reducing them down to 3 or 4
Okay.
on a regular basis. So that's encouraging.
Yeah, I would like to emphasize, so there's encouraging people out there that do this, do the same thing we just did. You take a list and you focus on it. You spend time and you whittle it down. You just whittle it down. That's takes an hour. That's like comprehensive geriatric assessment. Yes, in the back. Wow. Wow. So this. Yep. That's a very good point. That's where caregivers come in, nurses, therapists, anybody can look over the med list and make common sense decisions that, yeah, Grandma, you shouldn't take 2 ACE inhibitors. We had a patient in the group last week that they said someone was on 3 ACE inhibitors, 3 different ACE inhibitors from 3 different doctors. So yes, someone needs to drive the ship. Yeah, that's a great, so for Mesa, the question was, have I seen anything change with the electronic medical record? I've seen both positive and negative. The positive is there is a printed out list, which helps when you're leaving the clinic or you're leaving the hospital. It's typed out, so caregivers can read it, patients can read it. The negative I've seen is people depend too much on the accuracy of that. Everybody looks at it and says, oh, Miss Jones, are you taking this? And Mrs. Jones says, yeah, yes. You know, they would never refute. I mean, sometimes they do, luckily. So again, please, when you get to your clinicals, don't trust anything you read. Don't trust anything your teachers teach you. Go do it for yourself. Go look up stuff, and then go talk with the patient and the family members. Get the truth out. Yes? Thank you.
One thing that I think what you went through is just looking at each case individually and why are you on these, how can I change this, what can I get you off of, you don't need these things, you can't do a little bit of it. And you mentioned the HR stuff, and you'll find that in practice,
Yep.
you get watched more and more and graded. And what really counterproductive of this is, hey, your patient's got a cholesterol of this much, and why aren't they on a statin? And
Right.
for every, you get these notices too, for your patients that they're getting, the insurance company tracks what they're taking.
Yes.
For every one that you get that says, hey, this patient's on proven medicine, you still get another one that says, your patient's got this condition, we know that they're not taking a block or anything.
Right. That's what some of the studies of the pharmacists, the pharmacist intervention studies found that they would be able to cut, to 1 or 2 or 3 meds. But then the pharmacists based their decisions on guidelines, and so they would add 1 or 2 or more. So again, a good example is diabetes and the hemoglobin A1C. Finally, we have some good studies, depending on who you are, where you live, and your life expectancy, your A1C goal changes. Nursing home residents with dementia, their A1C goal is between 8 and 9, not 6. If you're frail, your goal might be between 7 and 8. A lot of... Yes. Yeah. Yeah. Very. It is very. That's a very good point to keep in mind for the young physicians. You'll be measured by the numbers instead of by your patients. So it's a challenge. Very good. Good point. Yes, Mesa, did you have a question?
Just had one question. Recently, I've seen a real uptick in aspirin, and other than platelet aggregation, is there anything else? Aspirin got a bad deal with the Rye syndrome, and then Tylenol recently, it's another one reason we replace the livers.
In young people, with overdoses. But yeah, go ahead.
But I'm just saying, I've seen a huge uptick in aspirin. I've got a patient right now who's been on aspirin 30 years, takes 30 aspirin a day.
You know,
No bad side effects.
I just had a patient recently that takes 14 or, yeah, I don't know what that is. So, yeah, aspirin as a pain medicine did get a bad rap because of the GI bleeding. So what are you thinking? Are you thinking there's some safety to aspirin?
Well, I don't know if there's bleeding, in these patients, unless they're using other thrombolytic, products or other
Right.
things.
Right.
But I'm just saying, it seems like that might be a safer drug, especially for younger people with chronic pain.
I think let's go, maybe I need to go revisit the literature on Tylenol and liver failure, because my impression was it was from people taking relative overdoses. Yeah, they're on it for pain, but they keep taking and escalating the pain meds, and then they overdose it that way, as opposed to someone who's being managed by a physician taking 6 a day or 4 a day. I think the old literature on anti-inflammatories is aspirin is a little higher risk for GI bleeds than the NSAIDs. So I think that literature still is out there, but it's a good question. Yes?
This might be a naive question, but if someone's in the hospital a year ago and gets, the Seroquel, for example, then who's refilling that for years or 2 years, 3 years later?
Yeah. Question is, who's refilling the medicine that was started in the hospital? Well, I'll be honest, it's been me before. In a busy clinic, you're in a busy private practice, you're seeing patients, you see the list, and the patient says, I'm out of this, this, and this. And now it's easier with EHR, you just click, click, click. If you have time, you said it takes time, why are you on this? Oh, let's delve back into it. So they did a study in Italy on this Pepsid, the H2 blockers, and in Italy, they use it a lot for prophylaxis in the hospital, which is unnecessary, but they looked at hospitalized patients on H2 blockers. 2/3 of that group did not need it, but the researchers didn't do anything except follow this group over a period of a year. And a year later, 2/3 of that 2/3 were still on the H2 blocker. So physicians, you'll be in their shoes soon enough. People want their prescriptions, and you'll refill them. So, yes. Yes, go ahead.
Is there concern taking a patient from 19 drugs down to 2 under the defense extra less expensive medications that they're trying to take them out from one place, especially that big of a jump?
In this lady's case, these are kind of not heavy-duty medicines, so it wouldn't be too bad. You might do it over 2 visits or 3 to get their confidence. There are drugs that you have to watch out and taper. Almost any drug that works in the brain, like gabapentin, some of the tricyclics, some of the antidepressants. Clonidine is a blood pressure pill that works in the brain. You have to slowly taper. Xanax, you have to slowly taper. So my general rule, if I think the drug works in the brain, I better look it up and see if I have to taper it. Yeah. Now, we do get, as a geriatric physician, a consultant, I will get patients from primary care physicians with list of medicines, and that whole goal is to reduce the list, and we'll spend an hour because we're consultants, and we'll whittle off 7 or 8 in one visit. Yeah. Yes, Janet?
Question about advertising on TV, medications, and has that changed how you handle medication choices with patients, or more patients come in asking for things?
Yeah, the question about advertising on TV, I do have patients come in asking me, I saw a new drug about arthritis. And so, first I'm always offended, well, I should know about it. But then I bite my tongue and say, okay, well, tell me about it. Let's look it up. So now, as you know, it really helps with the patient-physician rapport. I do this all the time. You look up the drug right in front of the patient on your handheld. And even if I prescribe a new drug, I'm looking it up, talking to the patient. And I think they feel a little more confident than the old days where the doctor was expected to know everything. You are careful because you're looking it up. So also, if people come in and ask me about alternative therapies, complementary therapies, I have patients that teach me about all that stuff, and they love it because they think they're teaching me, and they are, and I'll go look it up. But that gets rapport with the patient, though they trust me. And so if I go look it up and say, yeah, I looked at this, I don't think it's helping any, then I can tell them, okay, don't take that ginkgo or whatever. Yeah. So, okay. One more question? Did you remember your question? Yeah. There you go.
Very good argument.
I guess by teaching young physicians, don't believe anything you read. And if I can quote one of my mentors at St. Louis U is 50% approximately of what you learn in med school is going to be wrong in 10 years. So I'm sorry, but that's why we're doing research. And that's why it took 20 years to figure out the PSA problem. And now we have the mammogram. I just read a study about mammograms. For every, I want to remember these numbers, but roughly for every 3 lives out of 1,000 I save, and this is older women, this is women in, I think, above 70. Screening mammography, for every 3 lives out of 1,000 you save, you make a misdiagnosis of 19 or something like that. Misdiagnosis. It's not cancer, but they go through all the rigmarole of having all that stuff. So now I have good evidence to ask my patient who's 80. I say, if you're one of the 3 out of 1,000, let's keep doing this if you're really worried. If you're kind of a worrywart, you'll take your chances. Let's not do it. Same thing with PAPs and pelvic, family medicine. We used to do Pap smears and forever. And then finally, we've done the studies that your chance of getting cervical cancer is so low after 65 compared to getting up on the table and hurting your back that it's not worth doing. So that's a good point. We just have to do, this is why we have to do these studies. So, okay. All right, thanks. You've been a great group. Thank you very much.